and we'll be talking about femtosecond laser assisted AK. But before we do that, I'll just talk about some basics. What Himanshu very briefly alluded to in his talk. So the coupling ratio is something which you need to keep in mind whenever you are trying to do AK or LRIs in your practice. What happens is, like, whenever you put incision in your steep axis, so your axis which is 90 degree to that or perpendicular to that will flatten, and you can use this ratio for or this phenomenon to your advantage when you are planning a surgery. And you must always keep in mind, because otherwise it may also goes against the desired goals which we intend to achieve in this particular cases. So as Himanshu also said earlier, if the coupling ratio is 1:1, you maintain the spherical equivalent that you begin with. However, if the coupling ratio is more than 1, you end up having a hyperopic shift in your case. If the coupling ratio is less than 1, you get a myopic shift. So you can manipulate the coupling ratio, as I said, depending on the case you are dealing with and what you want to get at the end of the day. So if you increase the length of the incision and instead of use a longer incision and a single incision, asymmetric incision, that is, you just do not use the paired incision and use large optic zones, then you get a higher coupling ratio, which will end up having a hyperopic shift. So if you have a myopic spherical equivalent of your patient, you want to correct a bit of myopia in your astigmatic surgery, then you aim for a higher coupling ratio, and this is how you achieve it. If your patient is slightly on the hyperopic side and you want to have a little bit of a myopic shift, then you generally aim for a low coupling ratio. How do you do that? You generally aim for a 1 or 2 shorter incisions, which could also be radial incision, and they should be shorter, symmetrical, and pair incision, and preferably in a smaller optic zone. So this is diagram will explain you what you want to do. So if you have a smaller incision, if you have a average size incision, something like a 4 millimeter, and paired incision near the limbus, then you will get a coupling ratio which would be approximately 1:1. If you want as I said, basically a hyperopic shift, you want to correct a bit of a myopia, then you take a larger incision, something like a 8 millimeter single non-symmetric, non-paired single incision, a little larger one, which will give you a little hyperopic shift. If you want to have a myopic shift, then you take a multiple smaller and paired incisions. So in this case, you have taken 4 paired incisions, like 4 incisions are here, and these are smaller 2 millimeter incisions, and that will give you a myopic shift at the end of your astigmatic surgery. Then astigmatism can be either a natural occurring one, or it could be associated with cataract, or it could be a post-peak or a post-surgery astigmatism. So the naturally occurring astigmatism, again, you could either have a younger patient or you can have an older patient. Generally, a younger patient with astigmatism will not be a standalone astigmatism. The patient generally would have some kind of a myopia associated with it, or maybe a hyperopia associated with it. In the earlier days, before the advent of the laser surgeries, we used to generally deal with these patients by RK, or making, along with RK, doing astigmatic keratotomy or transverse incisions. However, the PERC study showed us that this does not really work very well. Patients ended up having a lot of irregular astigmatism, halos, glare, and a lot of many problems, and this is no more done for our patients. So the standard procedure these days for standalone, for younger patient with astigmatism, generally is PRK and or laser procedures such as LASIK. Talking about the older patient with astigmatism, generally these patients would be having cataracts. Again, it does not make much sense to go for only astigmatic surgery in these patients. However, you can do LRI along with your cataract surgery, or as Dr. Bhupesh just pointed out, you can toric IOL is a very wonderful tool for managing these patients. Of course, now with the advent of femtosecond laser-assisted cataract surgery, you can deal with cataract as well as the astigmatism in the same setting. Post-PK astigmatism, again, as was alluded to by Himanshu, either you can do a manual AK or you can do a femtosecond laser-assisted AK. Problem with the manual AK, of course, is that it is less precise. As far as the depth and the curvature of the incision is concerned, the results are not very predictable. And generally, you may end up with irregular astigmatism, which may cause halos or glares, and the patient is an unhappy patient at the end of the day. So that brings us to the use of the femtosecond laser in these situations. As we all know, it's a very precise laser, ultra short duration, which uses basically the phenomena of photodisruption, gives you a very precise cut at a very precise depth. So advantages with the femtosecond laser assisted AK are very obvious, that it is very precise and can give you a very precise centration because the associated docking involved with it, whereby you can manipulate the setting and fix it exactly over the pupil. You have a much better control on the depth and the curvature of the incision as compared to your manual incisions, and therefore the results are much more predictable. Femtosecond AK after PK, what you need to understand is here the basic your premise is that your graft host junction after the PK surgery becomes your new limbus rather than the original limbus. So the incision, whether it's a manual incision or a femtosecond laser assisted incision, this is made just about 0.5 or 1 millimeter inside the graft host junction after the PK. And you also need to understand that here your parameters are a little lower as compared to your other astigmatism where no PK had been done. So you titrate your incision so that for a lower depth and lower length of your arc of incision. So these are some of the nomograms which we follow in our practice. These are basically modification of the Lindstrom nomograms. These are for the astigmatic keratotomy, which is naturally occurring. And as I said, you titrate down the parameters, all the parameters, if you are doing it for the post-keratoplasty patients. So the depth is a little, as you can see, is less than as compared to what you will use for a naturally existing astigmatism. So it's about 75% as compared to 90% what you aim for on non-PK patients. So this is one of the video which we have done of femto AK. This has been done for a patient who has a naturally existing astigmatism. And as I said, the obvious advantage is that the surgery is very, very precise and controlled, and you can have a very predictable results at the end of the day. This is one of the patients with AK incisions. What is important is after the end of the surgery, you have to open these incisions with your Sinskey hook once you're done with the procedure. However, these are some of the results which we did about 6 patients of PK where we did the femtosecond AK. And as you can see, the surgically induced the cylinder which was corrected is about 6. But as if you remember the talk which Saurabh gave earlier, what you actually made a change was about 7.5 diopters. There are of course complications such as infections, microperforations, wound dehiscence, or graft rejection which can happen, or epithelial ingrowth also. Because of these associated risks, some people have now started doing what we call intrastomal femto-AK. I do not have any personal experience on this, but what you generally do is you make your cuts which are within the stroma. So what you aim for is less than about 60 micron deeper to you start your incision 60 micron deeper to the epithelium, and you make it shorter than about 100 micron to the endothelium. So you are within the stroma. You basically want to avoid both the Bowman's membrane, and you don't want to go anywhere near the endothelium. So that would be all about this session. If there are any questions, we will be happy to answer that. Thank you for your patient listening. If you have any questions or queries, you can also contact me on this email ID. We will be happy to answer your questions. Thank you.